Persistent ductus arteriosus, PDA, is a congenital heart defect where the ductus arteriosus, a blood vessel in the fetal heart that bypasses pulmonary circulation by connecting the pulmonary artery directly to the descending aorta, fails to close after birth. Normal physiology versus PDA. In utero, the ductus arteriosus is open in the fetus to divert blood away from the lungs, which are not yet in use. After birth, the ductus arteriosus typically closes within the first few days of life as part of the normal changes occurring in the circulatory system, redirecting blood to flow through the lungs for oxygenation. Pathophysiology of PDA. In PDA, the duct remains open, patent, allowing blood to flow abnormally from the aorta, higher pressure, back into the pulmonary artery, lower pressure. This results in increased blood flow to the lungs and overloading of the left side of the heart. Symptoms, mild cases, may be asymptomatic. Moderate to severe cases can lead to signs of heart failure such as rapid breathing, difficulty feeding, poor growth, and easy tiring. Physical exam, a characteristic machinery murmur is often heard on auscultation. Diagnosis, echocardiography, the main diagnostic tool providing detailed images of the heart and the patent ductus arteriosus. Chest X-ray may show signs of an enlarged heart and increased pulmonary vascular markings due to increased blood flow to the lungs. Electrocardiogram, ECG, generally used to assess the heart's electrical activity and to check for enlargement of the heart chambers. Treatment. The treatment approach depends on the size of the PDA and the severity of symptoms. 1. Observation. Small, asymptomatic PDAs might close on their own during the first year of life. 2. Medications. NSAIDs like indomethacin or ibuprofen are often used in preterm infants to encourage closure of the ductus. 3. Catheter-based procedures. A less invasive method where a coil or occluding device is inserted through the catheter to close the PDA. 4. Surgical ligation involves the surgical closure of the PDA, typically reserved for cases where catheter-based closure is not suitable or has been unsuccessful. Complications if untreated: pulmonary hypertension, heart failure, endocarditis, infection of the heart lining. High yield points. PDA is characterized by the failure of the ductus arteriosus to close after birth, leading to abnormal blood flow between the aorta and pulmonary artery. It can range from being asymptomatic to causing significant heart failure symptoms. Echocardiography is crucial for diagnosis. Treatment options include NSAID medication for preterm infants, catheter-based closure, or surgical ligation, depending on the PDA's size and the patient's symptoms. Early treatment can prevent complications such as pulmonary hypertension and heart failure. Involving a child with persistent ductus arteriosus. Case presentation. A 6-month-old female infant is brought to the pediatrician by her parents due to concerns about frequent respiratory infections and poor weight gain. They report the child seems to tire easily during feeding and breathes rapidly and heavily at times. History. Birth history: full-term delivery with no complications. Birth weight was within normal limits. Feeding: difficulty in sustaining feeds, with frequent breaks needed due to fatigue. Growth: the parents express concern that the child appears smaller and is gaining weight more slowly compared to peers of the same age. Physical examination. General appearance: the child appears slightly underweight for her age and mildly tachypneic, increased respiratory rate while resting. Vital signs: mild tachycardia, increased heart rate, respiratory rate at the upper limit of normal for age, normal blood pressure, and oxygen saturation in room air is 98%. Cardiovascular exam. A continuous machine-like murmur is auscultated at the left upper sternal border, characteristic of PDA. Respiratory exam. Clear lungs with no signs of congestion. Other exams. No significant findings. Shard diagnostic workup. Chest X-ray shows slight cardiomegaly, enlarged heart, and increased pulmonary vascular markings. Echocardiography confirms the presence of a moderate-sized patent ductus arteriosus with left to right shunt, causing volume overload on the left side of the heart. Electrocardiogram, ECG, normal sinus rhythm with signs of left atrial and ventricular enlargement. Management plan: Given the child's symptoms, size of the PDA, and evidence of volume overload, intervention is recommended to prevent complications such as pulmonary hypertension and heart failure. 1. Referral. The child is referred to a pediatric cardiologist for further evaluation and management. 2. Treatment options. The cardiologist discusses the possibility of catheter-based closure of the PDA, which is a minimally invasive procedure often preferred in such cases. The family is counseled about the procedure, its benefits, and potential risks. 3. Follow-up. Regular follow-ups are scheduled to monitor the child's growth, development, and heart function post-intervention. Outcome. The catheter-based procedure is successfully performed without complications. At subsequent follow-up visits, the child shows improvement in feeding and activity levels. Growth catches up gradually over the next several months, and the respiratory issues diminish. The echocardiogram shows no residual shunt, and the heart size returns to normal on the chest X-ray. Discussion points. Early recognition and treatment of PDA can prevent long-term complications. The decision between medical management, catheter-based intervention, or surgical ligation depends on various factors, including the size of the PDA, symptoms, age of the patient, and presence of other medical conditions. Comprehensive care involves not only addressing the PDA, but also supporting nutritional needs and overall development of the child.